Top Bed Talk.
Well, I learned lots of things about William when I was on council with him. One was that as you probably detected about halfway through, he's a terrible pedant for grammar. And I don't know enough grammar to be a pedant. The other is that he's usually right. He's quite thoughtful. Not always. There are still things I'm sure we disagree about, but he is usually right. And I have to say that in this regard, we've talked about this long and hard in council, and I agree with you. But it's going to be a hard journey.
I'm going to hold that moment in my mind forever. Saying,
but thank you for a magnificent presentation. There are only about 25 questions, and they're coming in thick and fast. So, William, quick fire, 25 questions.
Yes.
Starting with, as someone coming from outside the NHS, I know there are a lot of international medical graduates ready to come to the UK, clinically qualified, as well as to maybe bring on more international medical graduates. But is that a solution to the problem?
It doesn't get away from the overall cost envelope and trying to provide more of safe practice within the same cost envelope. I know that a lot of international medical graduates will be concerned about the growth of anaesthesia associates because it may stem the entry of international medical graduates. But as I said right at the beginning, we need lots of people of all sorts and from all places keep coming, and I don't think it will adversely impact.
Next one says several comments about retiring anaesthetists, and I know lots of anaesthetists who are retiring early. Isn't this just shifting a problem within the NHS? Experienced ODPs moving in to become AAs, making the pool of ODPs smaller, or similarly nurses?
Yes, so we are well aware of this, and although most of the AAs in the UK at the moment were originally ODPs, the big pressure is on from HEE to draw student AAs from the science graduate pool, because we do not want to take away the people who may be the best ODPs and denude that population. But also I think they will be training more ODPs to compensate for this as well, but that's not the vision, taking away your ODPs.
I'm going to let this one jump the queue because I rather like it. What do you say to trainees who are just starting off and thinking, I could do a 2-year AA course and learn relatively well and do no on-calls?
I've been asked this question before, and it's look to the future and what you'll get the most satisfaction, pleasure and reward from, and allow you to do the other things in your life that you wish to do. If you think that is other roles like A or SAS doctor, then by all means consider going to it. But there's no reason that you should not continue as a trainee to become a consultant.
We're going to overrun if you don't mind.
It's your meeting, not mine.
Good. And I'm also relieved. So the American nurse anaesthetists were in the room for most of it, and thankfully the American anesthesiologists were largely out of the room, so no pain was caused, I think. What about responsibility when supervising AA? Where does the liability lie if an AA refuses to take advice or makes a mistake?
So within the trust system within the National Health Service, trusts are vicariously liable for the actions or inaction of their employees. That does not change at all. That the AA is individual as a registered healthcare professional, and they will be registered soon, responsible for their own actions. Consultants or supervising senior SAS or senior or specialist grade doctors take clinical responsibility when they are involved in just the same way that you would for an anaesthetic trainee. There is no change to that at all. So it's a good question and an often asked question, but the situation is exactly the same as it is now.
Okay, next one. How do you manage a situation where, due to on-call, days off, etc., trainees end up doing fewer elective lists than their non-medical colleagues who are around during the day?
Well, this is how you could start to look at the use of anaesthesia associates in out-of-hours work. And providing you have the correctly trained anaesthesia associates with sufficient experience and the appropriate level of consultant supervision, you could actually have anaesthesia associates providing some of the on-call duties, because not all on-call duties are giving anaesthetics. There's an awful lot of other stuff that goes on, tweaking PCA pumps, doing some pre-assessment, checking out pain on the wards afterwards, that could be done by anaesthesia associates to liberate more trainees to actual training during the weekday. That, I think, is a serious prospect. It frightens some people, but I think there are opportunities there.
This is arguably a question for both of us, and indeed Monty and anybody else who's previously on council, but I'm very happy to let you take it.
Thank you very much indeed, Professor Grocott.
Is the use of anaesthesia associates more a demonstration of the failure of the Royal College of Anaesthetists by creating such a long training programme?
What a fantastic... Who asked that? Have we got a name?
I don't know.
I have special skills. I will find you and track you down. I'm going to take that as a rhetorical question. I think the statistics of this country and the safety of the anaesthesia that we have historically provided demonstrate that what the Royal College of Anaesthetists has done over these past only 25 years, but we have a previous incarnation, has been the right thing to do, because our standards of safety in anaesthesia in this country are very high, and it is our absolute determination to make sure that they do not slip in any way, shape or form. Safety will always come first to us.
There's a hand up in the audience.
See if it's working. Hi, my name is Charlie McFarlane. I'm from Auckland. Originally started here. Just a quick comment. I won't talk about the lifestyle stuff and the respects and things, but when you do the maths there, you're paying the assistant roughly half a specialist fee. It means you have to, before we start, we were looking at this to a certain extent, and I heard some discussions around it. You've basically got to supervise 3 or more before you start actually saving money. So when you're talking about value and saving money, and when we were looking at it and just looking at the way that they'd be rostered on a more nurse-based rostering, the number didn't really work out. It didn't make any change, and you just might as well employ one specialist in the 2 theatres.
That's a really, really good point. So I would come back and say, yes, that is a relevant point, that if you've got one consultant supervising 2 AAs, then it's the same price as 2 consultants. And that's absolutely true, except somebody's going to get breaks in the first model and nobody's going to get a break at all in the second model, which is not an inconsiderable point of view. The second point of view is that a lot of anaesthetists do a lot of duties now which do not take anaesthetists, because anaesthesia is not just the administration of anesthesia, and there are lots of tasks that could be done by an anaesthesia associate for which they do not need supervision, that could take the pressure and be cheaper than the consultant anaesthetist. And I reiterate my point of view of training, because the NHS is looking at the totality, not just the minutes time on the spot. I know hospitals are, because they're up against it. From the NHS as a whole, they're looking at training these people. Training costs an awful lot. 14, 15, 16 years of training is expensive. 2 years, 3 months is not as expensive. So completely take your point. Until you get to 1 to 3, 1 to 4, there's no immediate cost saving, but that's just for the administration of anaesthetics. Do give me a follow-up.
Yes, certainly true. With us, I don't know what the ODPs do here, but our techs have taken over doing all the PIC lines and midlines and difficult IV access with ultrasounds and everything like that, which is fantastic, actually. Yeah.
What about using some money, I presume the same money, to retain anaesthetic trainees, i.e. presumably reward them a little bit better? HE continues to cut trainee numbers when we know that we can recruit more excellent CTs and registrars, CT/registrars.
It is an absolute tragedy that in the last ST3 recruitment round in England and in the UK, that there were many more competent, enthusiastic people who wished to start a career in higher training in anaesthesia than there were posts for them. That is awful, and we would love to see a great expanse in the number of higher training posts in anaesthesia in this country. I'm delighted to say that we are seeing an increase, and we've got an extra, don't laugh when I say they've got an extra 70 out of health education in England, which is not many, but it's better than none. What we are actually very interested in, and Mike, you can tell me whether we are also pleased, because I'm quite pleased, is the growth of the CSER training programme. That hospitals, particularly in the larger cities, are now creating their own CSER pathway training programs to provide these people who wish to become anaesthetists the opportunity to get high-quality training. And that, I think, is going to become a growing way. The HEE may try and control the workforce and control the numbers with NTNs, but I think that the enthusiasm of medical graduates for anaesthesia will see a growth of CSER programs and a lot of people going through that way. And I think it will not be a second-class way of becoming a consultant. It will be at least equal.
I completely agree with you, and I also think it offers. So most of us trained in a fairly different way to the very structured way now, and I think it offers people alternative career pathways to consultant level, and we should consider them as absolutely equivalent.
Yeah. And if you talk to a CSER trainee and you say, join our program, you'll have one employer for your whole higher training, and nobody will screw up your tax code, and you will be able to pay your mortgage. And they do a dance. This is incredible.
Right. If consultants are continuously involved with high-risk patients, does this carry the risk of burnout and early retirement?
Thank you for that question. That's absolutely brilliant. And I did make the point of saying how nice gynae anaesthesia, not specifically gynae, but I have young colleagues who've talked to me who made exactly this point. They spend most of their time doing vascular, peds, major upper GI, and one of them said to me, William, do not take my gynae daycare list every other week, my 1 day every other week. It's where I find my sanity. It is where my heart rate is lowest. It keeps me mentally well. I am very, very, very well aware that everything you do in life must be a balance, and that just to make consultants either supervise or do major stuff may not lead to great health, and that must be brought in. And whoever asked that question, that is a great question.
That's a great question. Sort of point of information, what is a CSER program? Because we've got quite a few non-UK folk and we assumed...
Okay, so I'm going to try and remember what CSER stands for. Certificate of anyway. So most people getting their CCT, the Certificate of Completion of Training, go through a program which they have a national training number, which is approved and part funded by Health Education England. So it carefully controls the numbers going into the specialty and through to CCT. CSER is an alternative pathway to entry onto the GMC's Medical Specialist Register, which CCT gives you. You have to provide, at the moment, eye-watering documentation, literally hundreds of pages of all the cases you've ever done in your entire life, which for people coming in from abroad is complete madness. But it is a way of doing it, and I'm delighted to say that the GMC is in the process of simplifying that so that the information that you give as a CCT is the same as a CSER, that alternate pathway, and that they can both hopefully be able to use the lifelong learning program of the Royal College of Anaesthetists to document their learning and document their cases. So it's an alternative path.
Kay Mitchell at home with her broken ankle. Will anaesthesia associates be encouraged to engage with research, not only facilitating but engaging in leading research?
Yes, is the simple answer. You saw on their general professional capabilities that research was included. Those with the interest and the capability should be drawn into research, should be drawn into management, certainly teaching. Why not? If they are the right people to do that, I, for one, would not stand in their way.
Guy Ludbrook in the room. Professor from Adelaide, those who piloted PAs in Australia 15 years ago still have PTSD. There is more. What strategies are needed to manage any weak workforce transformation well and less painfully?
So what you're suggesting is I should get help soon, basically.
Microphone coming.
We had the same workforce problems that you have now. It was very confrontational. Things have settled down now, but we will face the same problem again. So it's come around again. Yeah. But it's very emotional, very challenging, very tough. And I'm not planning to do it again. But if we did, knowing how to do it slightly more wisely would be helpful. We need to talk to people from your country and get your experience. I do not underestimate the difficulties ahead and the strength of feeling there is in speciality, and certainly talking to people with your experience in a quiet room, obviously lights turned down low, both on couches, would be fantastic.
How do you guard against mission creep? As in role extension, role equivalence?
The answer is I don't think you fear mission creep. What is mission creep? If mission creep includes somebody who's got the enthusiasm, intelligence, experience, knowledge and skills to do something, should they not do it? Or do you stop them doing it simply because their title is anaesthesia associate or anesthesiologist? Mission creep is a fear, but if mission creep includes a better service to the patient, let's creep. Let's do some creeping. We're going to have to feel our way, and I understand the fears and concerns of people out there, but I really do think that the choice of, if we don't play our part in this, the world will end up worse for us and our patients.
Please.
Okay, Scott Brudney. I actually work in Canada, and the way you presented this was really excellent. I love the incorporation of the team, the referencing to the US as to what we shouldn't do. And interestingly, hearing from Australia and New Zealand, Canada is there as well. Because we are not going about this well, it's heading towards that US model where the government is actually mandating that we will be using these alternative providers. And because you haven't got a government at the moment, maybe...
Nobody tells me anything.
Maybe it's good that you carry on doing this. Thank you.
Thank you for that.
Desiree Chappell, Louisville, Kentucky, USA, certified registered nurse and anesthetist. Some may call themselves nurse anesthesiologist. I am not one of those. I have to commend you guys for doing this. I mean, this is a very difficult task. There are many lessons learned from the U.S. that I would implore you, which you already are, but to definitely talk to some of us on the other side in the U.S. to see how there may be ways to do this better. There definitely is. Rising tides float all boats. And so if there's more resistance to educate the people who you are bringing in to help the greater good, our patients first, each other second, if you can educate them and empower them with knowledge and the expertise everyone wins in the end. And that's my take on things. Everyone else may.
Just to add to that, what I didn't stress is that I've worked in the States, I've worked with nurse anesthetists and anesthesiologists, and there are lots of examples of very functional teams of anesthesiologists and nurse anesthetists who work really well together and are a cohesive unit. There are other examples. The leadership is more at each other's throats than the individuals.
And it's the fringe. I mean, we hear so much from those on complete opposite sides with the loudest voice in politics and everything else. It's the same way with the AANA and ASA, and there's just a better way to do it. And you guys are like right there to do it really, really well.
In the same organisation, to me, that's so important.
Yep.
So we have our abstract competition in 3 minutes. I'm going to leave you with 2 questions. You can choose to answer either or neither.
I can answer neither of them.
You can. If you were a patient, would you rather be anaesthetised by someone who has 2 years training or 7 years training? And then the other one, which I rather liked, basically said, we're getting degraded. Will it all be robotic and AI anaesthesia soon?
The answer is we are not getting degraded. Having another member of the team who does some of the work that you would have normally done does not degrade you. These people are called obstetricians. For centuries, they've had midwives doing all their work for them apart from section. And yet people do not look down on obstetricians in any way, shape or form. And the answer is, would I be happy to have an anaesthesia associate anaesthetize me? I would be happy, providing that person had the knowledge, skills and experience and was under the supervision of a consultant anaesthetist, and that's the way we plan it in this country.
William, honestly, a heartfelt thank you for an interesting, challenging and properly provocative debate. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.